Hello and welcome to the Headache Doctor podcast, where on this podcast, it's our mission to educate and empower everyone with headaches and migraines so that you can break free from a life of fear of your next headache or migraine and dependence on medication. In today's podcast, we're going to talk about one of the things that we have been seeing connected to headaches and migraines, a critical contributor to a lot of people's presentations with headaches and migraines, and that's Ehlers-Danlos Syndrome. Abbreviated EDS. So from here on out, I'll refer to it as EDS, but it's Ehlers-Danlos Syndrome. This is a syndrome that many of you may be familiar with. Maybe you're not. We're going to talk about some of the common symptoms that you would see and understand if this is something that might impact you. Generally, we're just talking about hypermobility, but there's more specific things that you can do to test this on yourself. Of course, going into a provider that can officially diagnose this is appropriate before you go on thinking you might have Ehlers-Danlos. But this podcast is all about educating and empowerment. And so we're going to talk about what it looks like to have hypermobility, the impacts of that on the body, and then specifically Ehlers-Danlos Syndrome. And then we're going to talk about things that you can do to help yourself improve your quality of life, how your body functions to overcome what might be more joint laxity or mobility than what would be normal or typical. Okay? So let's define what Ehlers-Danlos Syndrome is. So EDS is a genetic connective tissue disorder. So really it impacts collagen, and its impact on collagen means that there's all sorts of tissues and structures in the body that are impacted by EDS. One of the most common symptoms that we see in patients is a hypermobility that is throughout their body. All right. So collagen is dysfunctional, leading to hypermobility in joints, tissue fragility, and then instability. So think of the body as made up of muscles, tendons, ligaments, and then the bone structures themselves. And there's a balance between stability and mobility that everyone needs to be able to balance those two well. And the dynamic of your individual body being able to balance those well will dictate your ability to tolerate stress throughout the day and what you physically put your body through. Some people can be on the stiffer side of life and they don't move well, which can pose problems. And other people can be on the more mobile side of life. So we have stability when we're stiff and things don't move well. So there's not much risk for there being a movement problem in the sense of like dislocation or the joint's not stable as it functions because the joint's all stiff and locked in there. When it moves more than it should, then we look at that sort of as an issue because we've got muscle, we've got other parts of our musculoskeletal system, primarily muscle, that has to coordinate well enough and be trained well enough to add the stability that's not naturally there within the joint. So when we talk about joint laxity or hypermobility, it's really talking about two bones interacting that create the joint itself, and then the ligaments that surround the joint having more movement than they should. And so there's more wiggle room within the joint. And because there's more wiggle room, oftentimes the musculature around that joint needs to work harder and kick in throughout the day in order to stabilize and allow that your body to move and function, compensating for the lack of stability. Okay, so the stability it's found through other means, as opposed to just what naturally would be there through the ligaments, tendons, and the joint structure itself. There's a few different subtypes of EDS, but we're just going to focus on hypermobile EDS for the purpose of our conversations. And just know there's associations with all sorts of things, but GI issues, fatigue, and then dysautonomia. And we're going to talk about dysautonomia a little bit. So just to define what that means. So our autonomic nervous system is made up of the sympathetic and the parasympathetic. So the sympathetic is our fight or flight, and our parasympathetic is our rest and digest. Okay, so again, we have this spectrum of these two different automatic responses that impact just about every system in our body. So whether that's heart rate, blood vessels, our muscle tone, fast twitch versus slow twitch muscle fibers, how much blood's allocated to our brain, what our brain's focusing on, our response to pain, what our nervous system's doing. So all of these different systems are impacted by the autonomic nervous system. And so when we use the term dysautonomia, that basically just means your body is not able to regulate those two systems properly, okay? So it could be that you're bouncing from one to the other really quickly, or you're stuck in the sympathetic nervous system response, so you can't really calm down. Or it could be that a situation like POTS, where your body can't respond to position changes, and so your heart rate's got like this improper response. The blood's not getting to your head. You feel like you're going to pass out. And so that would be an example of dysautonomia that oftentimes is associated with EDS. So POTS is postural orthostatic tachycardic syndrome. So your heart rate elevates in an inappropriate way in response to position changes. So that's what the postural part of that is. So we'll talk a little bit more about that. Okay, so how can EDS connect to headaches and migraines? So we do know that when an individual has the diagnosis of EDS, they're more likely to experience headaches and migraines. There are some studies that say up to 75% of patients diagnosed with EDS are going to present with migraine symptoms as well. The related conditions in addition to that are POTS, oftentimes TMJ dysfunction, so the jaw not functioning like it should, potentially a Chiari malformation. I know that we have several people, either listeners of the podcast or people that we've seen, that present with Chiari malformations and have asked us about that. And then also cervicogenic headaches. And then there's another condition called mast cell activation syndrome. And so mast cells are, it's a different line of thinking, because when we're talking about mast cells are essentially these white blood cells that release an inflammatory response. And so basically when you have mast cell activation syndrome, it's a syndrome that says those mast cells are responding inappropriately. So whether it's that there's not a threat of anything inflammatory, or it's just they're overactive. So basically there's a higher level of inflammation running through your system because of this mast cell issue, which is also shown to be connected to EDS. They call it, it sounds awful because it would be rough to have all three, but they call it the trifecta when it's EDS, POTS, and then mast cell. But we're going to talk about what are some practical things that you can do, and then obviously educate you so you can understand how to manage these three things. Now, don't hear me say that, well, first off, this is a podcast and I'm speaking in general terms. So disclaimer, if you feel like I'm describing you, then work with a real in-person provider that can help you understand these, maybe, and make a proper diagnosis. Don't go diagnosing yourself based off of what I'm saying here. Just use this information as, okay, here's something else that I can maybe pursue, and then a helpful framework to understand it, and then an avenue to move forward. So there's something called the Baton score. And so when we're evaluating EDS in your own situation or with a provider, there's actually a fairly simple test. So we're just looking at joint laxity, how much joint mobility you have. And so there's a few things that you can do, and they're real easy. So you can take your thumb and basically pull it down so that it meets your wrist. It's called opposition. So basically, if you're watching on YouTube, it looks kind of like this. Like you're taking your thumb and you're trying to touch your wrist. Now, if you are hypermobile, double jointed, you've probably used this as a party trick. You're like, look at what I can do with my thumb. The other thing you can look at is the extension, or it would be dorsiflexion of the little finger. And so your pinky finger, just sort of bend it back. If it's greater than 90 degrees, that would be one of the signs. So thumb to forearm, if you can touch your thumb to forearm, if you can bend your pinky back greater than 90 degrees. Elbow and knee. So if your elbows and knees are able to hyperextend past that 10 degrees, that's also one of the indicators. So there's 5 things here. So elbow, knee extension, and then we've got pinky finger and thumb mobility, and then basically just forward bends. So with your legs straight, can you get your palms to lay flat on the floor? Okay. Now you get a point for each of those. So we've got basically a point on either side. So if both knees and both elbows extend past 10 degrees, and then if you're able to get your thumb on both sides to touch your wrist, and then if we're able to extend the pinky finger, that would be, what would be 2, 4, 6, 8, that'd be 8 points. And then an additional point if you can put your palms all the way on the ground. Okay. So how they score this is, in general, if you're greater than or equal to 5 out of 9, that would indicate generalized joint hypermobility in adults. Children and adolescents, if you're greater or equal to 6 out of 9 of those, that would be a generalized joint hypermobility. Kids are just generally more flexible, and so that's why they add a point there in order to meet that threshold. And then adults over the age of 50, just because we tend to naturally lose flexibility as we age, would be a 4 out of 9. Okay. I'm pretty sure that I'm at 0. So I definitely can't put my palms on the ground. I'm probably on the tighter side of life. But something you can do to test this on yourself. Now, if you meet those thresholds, it does not mean you have EDS. It just means that you have very mobile joints, okay? And so there's other indicators such as genetics that we use, family history, that sort of thing, to understand if you have officially the diagnosis of EDS. And there are certain providers that you should see that do this type of thing, provide the diagnosis of EDS on a regular basis before you go assuming you have EDS, okay? But just interesting to look at joint mobility, and then we'll talk about the implication of that with headaches and migraines, okay? Now, we are a physical therapy specialty practice that works with people that have headaches and migraines, all right? So we're working on the physical body, we're working on mobility and restoring mobility, and we do see hypermobility as an increased risk of developing headaches and migraines. There's just a higher prevalence of people, especially females, that are hypermobile, little kids, hypermobile, that their body, their necks, their shoulders can't sustain the level of activity they throw at it. It lacks the stability. So over time, they develop a lot of tension because their body's just trying to cope and manage with what they throw at it throughout the day. Okay. Before we jump into more of that, a couple other things you can look for as far as symptoms to think, okay, am I in this category? Frequent joint dislocations, subluxations, and even like stretchy skin, chronic fatigue, easy bruising, things like that. And so lots of people, well, I would say that it's relatively missed diagnosis. Now, if you've gone through our process here at Novera, just know that we often, well, one, we're not officially able to make that diagnosis. And so we generally, we're not going around providing this diagnosis to people. Two, we treat what we find. And so it's not necessarily a conversation that we have with a ton of people of, oh, you might have EDS, partially because having another diagnosis for some can be helpful in just understanding their journey. And for others can be like, okay, this is just, it's almost like more crippling. And so if we just say, hey, these things need to improve in your neck, shoulders, and jaw, and the body should respond, and we're going to move forward and we should see an impact. That's a much simpler approach. And we just find the problem and we provide a solution and then we get the result. So having a diagnosis of EDS doesn't mean you're just necessarily doomed to always have migraines or have these symptoms. There are ways to manage it. It just may mean that you're in a category of you have to be more aware of your neck and shoulders and jaw and how your body in general is going to function. And that extra awareness and care is going to be needed in order to stay symptom-free and be able to manage things like headaches and migraines. So when it comes to applying our lens into someone who has hypermobility, EDS, now historically, we've seen quite a few people with EDS, and we've seen quite a few people with POTS, and I'm sure mast cell has been in there as well. Oftentimes those three go together, but essentially higher level of inflammation, difficulty with position changes, and then hypermobility. Okay, those three things. Now, we've successfully treated, headaches and migraines in people with EDS and just general hypermobility. And then not directly, like the patient didn't come to us with POTS, but we've seen those symptoms reduce as well going through a process. So what do I think is happening here? So cervical instability, so meaning instability of the neck, of the shoulders, of the jaw. So when it's hypermobile, it's not as stable. And that leads to added stress through the joints themselves. Maybe muscle tension increases. And so what we often find is that the mid-neck is very mobile, and even the upper part of the neck is very mobile. We usually find patients, let's say it's a female in their 40s or 50s, and the upper two joints will still be very, very tight and restricted, okay? So there's a level of stress placed through those two joints that the body's sort of forgotten to use them. And because the mid-neck is so mobile, they're able to navigate like rotation, look up and down. So they're compensating really well without even utilizing the upper segments of their neck. And so hypermobility is often something that leads to specific segments of the body having more stress and potentially needing to move again like they should. So that's one thing. The other thing is when we have this hypermobility, there's a lot of muscle tension. So the muscles kind of work as a web to provide the stability that's not there. And so we need the muscles to coordinate and function really well. And oftentimes we just need to calm them down. So they've been so wound up because they have to hold everything together for so long that us physically working on the body helps to calm them down. So we see this in the shoulder as well. The shoulder is made up of a bunch of different muscle groups that the only attachment to the actual skeleton of the body of the shoulder is through the clavicle. And so the clavicle inserts into the sternum, and that's the only attachment point. So the rest of the shoulder blade and the shoulder is basically floating, all right? So it's moved and positioned in response to muscle coordination around the shoulder. So that's in the pecs, that's in the back. We have the rotator cuff muscles. We have muscles like the upper trap and the levator scapula that run into the neck. So we've got all these different muscle groups on every side of the shoulder and of the shoulder blade that are already having to just naturally coordinate well in order for the shoulders to function well. But when we add hypermobility and instability, that coordination can be compromised in a sense, where it's not coordinated or efficient like it should be, and so we have increased stress, dysfunction, or what's called dyskinesis, like the movement pattern is not moving like it should, and so that increases the amount of stress over time and does play into increased stress on the neck. And because that levator scapula, which is a shoulder muscle, inserts into the upper part of the neck, it's just constantly pulling. That's another reason we see the upper neck take on a lot of that stress and not really want to move like it should. And then we also see this in the jaw. So the jaw can be hypermobile. So the jaw responds to where the teeth are located. The teeth want to connect, and when you bite, The teeth know where they should be, and so the teeth will find each other. And if the jaw is really hypermobile, the jaw joint itself, the jaw will kind of react in a way that over time adds wear and tear and stress. We also can see increased muscle tone or muscle tension around the jaw, which again is something that we can physically work to reduce and then restore function and mobility. Okay. So what we want to do to combat this sort of hypermobility problem is to build stability. Okay. So if we don't intentionally take action to build stability in the neck or the shoulders, our body will naturally go down this avenue of compensation. And so those compensations over time is what leads to the problems that are causing the headaches or the migraines. The stability, though, is in specific exercises in order to train big muscles, small muscles. Say, this is what should happen when my shoulder is in a neutral position, engaging the deep neck flexors in the neck so that the neck doesn't rely on just these accessory muscles, which are already kind of worn out and fatigued. So it's building up stability. Dr. Romero, I was talking to him earlier today about this, and he was saying how a lot of gymnasts or young dancers that have EDS or have hypermobility, when they're in their sport, will do relatively well as far as like having the muscle coordination and stability to hold things together. But when they leave the sport and they just sort of go on with life, they're not as active or exercising or maintaining that level of muscle stability as a compensation pattern, then they start to have the issues that would have been there if they weren't involved in their sport. So we want to maintain a level of stability appropriately, engaging the specific muscles that our neck and shoulders need to function well throughout the day. Improving posture and just awareness of the positions you sustain throughout the day. So again, if we lack stability, stability is something that we want when we move, but it's also something that helps us when we're sedentary and when we're not moving. And so if we lack stability and we sit still, that forward head position or the sedentary positions that we sustain are going to have that much more impact on you. It'll feel like I can't hold my head up, like all of my muscles are just constantly tight because my head and neck don't really know what to do. They don't know where to rest. And so implementing movement throughout the day and being aware of your posture so that you're not adding stress with forward head positions, forward shoulder positions, things like that. And then ultimately, I would say seeking out a provider that understands this. When it comes to headaches and migraines, like I said, we do see a lot of people with, or a high prevalence of our patients have that hypermobile presentation of their joints. They've compensated through the years and gotten to a point where like their neck, jaw, shoulders, like everything's just really flared up. And we're able to calm that down, but leaving there, we need a higher level of awareness of how do I maintain this and keep my body in good shape. So educating yourself on, okay, I might be in this category as, we'll put it like higher risk for developing musculoskeletal issues or having higher stress through these systems because of the hypermobility. A lot of people will ask like, well, why am I in this situation? Why did I get here? And this could be one of the reasons. So hypermobility doesn't just mean you automatically have migraines, but it does mean you're at higher risk for developing these types of injuries, and these types of injuries present as migraine headaches. So that's sort of the rabbit trail. And when we understand that path to where you are today, then we can start taking the steps to work backwards. And there's that common theme in there. Okay, so EDS, how it impacts the body, its connection to POTS and mast cell. I'm not going to go on specific descriptions of POTS and mast cell past what I already said. Actually, Dr. Morris did a podcast a few years back, and he talked about mast cell. And so that is something that we've heard on the podcast before, but essentially just inflammation a higher level of inflammation as those mast cells are acting in a sort of inappropriate or in a way that's excessive, and then POTS being connected as well, has potentially has impact from neck tension and the sort of mechanical dysfunction we've been talking about, impacting your body's ability to regulate heart rate, blood pressure, those autonomic functions as well. I've had a few people recently that just present with autonomic dysfunction and have done really well when we clear their neck up, their vagus nerve. All of the communication of the sympathetic, parasympathetic nervous system is impacted physically when our body's carrying tension. So if we clear one thing up, we start to see lots of things clear up. All right, so there you go. There's EDS. I hope this is helpful for you. This is a new topic. We haven't talked about this on the podcast, but I had a few people bring it up, and I thought it would be helpful. So let us know. Email us at hello@noveraheadachecenter.com and provide any other topics that you might want to hear. And I appreciate you all so much for being weekly listeners to the Headache Doctor podcast. If you're able to, write us a review, 5-star review. Let us know what you've appreciated about the podcast. Share it with a friend. Send it to someone you know who would benefit from it. You're our only marketing strategy. And so we need you guys to spread the word. We're on a mission, as I always say, to educate and empower everyone with headaches and migraines so that you can break free from a life of fear of your next headache or migraine or dependence on medication. I'll see you next week.